Can keep things rolling. Thank you, Katie. So, welcome to the third installment of our Pediatric to Adult Healthcare Transition in Minnesota series. We are wonderfully funded from all of the organizations listed here, and have technical support, of course, from Project Echo. Next slide. The aim of our Healthcare Transition Collaborative is to transform Minnesota healthcare systems to provide equitable, accessible, and trauma-informed pediatric to adult healthcare transition for all Minnesotans. Of course, gleaning from everyone that brings experience from outside of Minnesota, and hopefully to instill knowledge back and forth, which is the ECHO model. Next slide. Acknowledgements, of course, we could not do this work without the wonderful funding from the Minnesota Department of Health, our partners at Got Transition, the ECHO Institute in New Mexico, our core faculty and steering work group, which are listed on our website and will be on our next slide. So here is our core faculty who will be involved in the discussion today and also leading different parts. I will draw attention to Debbie Harris, who's our lived experience expert and will be leading some of the discussion today. And our greater steering work group, again, really thinking about developing a team that is guiding this work with a variety of perspectives from across the state in many different roles as well. And their bios are all on our website. This is, of course, you can get CME accredited or CME credit for today's session. Next, it's 1 physician hour, which can then be utilized through different boards as well. All of that information will come in your email after today's visit for attending. We would love to enhance this learning collaborative by turning on your video so we can get to know you, muting unless you're speaking. You can always raise your hand at any time. We'll be watching for that. Otherwise, dropping a question into the chat. And introduce yourself when you're asking a question. And also encourage you to introduce yourself in the chat so we know who is all here. Next slide. Structure of our session today, we're doing the welcome and introduction right now. We'll have our didactic presentation next, and then a collaborative case discussion where we want everyone's input on a very exciting case, and then we'll wrap up. If you have a case related to transition, we would love for you to have this platform to be able to talk through it. So it could be an individual case of a patient that you're seeing in your clinic, or it could be that you're trying to implement some sort of transition process in your clinic and are kind of stumped how to do it. It can be a very small question. There is such a wealth of experience on this call to learn from. So we welcome anything. When we have cases like we will later today, we are not establishing any provider or patient relationships. It is merely for providers to talk amongst each other and clinicians to figure out how we can best care for patients overall. So with no further ado, I get to introduce the wonderful Dr. Peter Scal. He is a pediatrician and health researcher at the University of Minnesota. And one of my early mentors in terms of transition. So I got to rotate with Dr. Scal on my adolescent rotation and really just learned a wealth of information about this world of transition and how you can actually make it a part of your life. So I'm very excited to introduce him, and he'll be talking about engaging with others to improve healthcare transition. Thanks, Dr. Scal.
Thank you so much, Tori. It's really a pleasure to be here. And I do remember the time you were with me in clinic at St. Joe's talking about, I was more excited to talk transition than the actual patients we were seeing, but we got it both done, I think. And I'm so glad you're doing what you're doing at Gillette. And thank you for inviting me to be part of this group. It's really a great lineup of people and organizations, and I'm just thrilled. As you mentioned the title of my presentation, I want to acknowledge that the visuals I created for this were made by AI, by DALL-E. So if you see something that looks concerning, like it's yours or something, please let me know and I'll remove it. But I'm pretty sure they're all just novel creations. And let me know if you think they're useful or not. You know, I love the topic of transition. It's been the work that I've been doing since I was a medical student and working in the Division of Adolescent Health at the University of Minnesota way back. University of Minnesota has a long history of doing transition work, and it was nearly 30 years ago that our division, Adolescent Health, and the health department in Minnesota and Shriners Hospital developed the first transition clinic for youth in Minnesota, and that was 1994. It didn't last long, but it was the first good start, and just reminds us got to keep at it. But today I'm really excited to talk about engaging with others, because there's no area where I've been more surprised of what I learn than it is when I'm engaging with others. I can always count on something new when I'm there, and for me that's just a bonus. I love it when I'm learning from other people. Next slide, please. Where am I supposed to do it?
Nope, I did it. Can you see?
Okay,
sorry,
I'm sorry. I was
might be
looking at the
kind of
wrong one. Yep.
Sorry. Okay, just checking.
I was looking at the wrong one. All right. So I have no disclosures to make. I haven't yet invented a transition tool that we can all use. So maybe next time. Let me move on to why engage with others. Engaging with others is vital for our success, right? So no one here in this group has been able to do it alone yet. And I don't think any of us are going to be able to solve this problem in the future by ourselves. It will take a crowd to make this happen. And when I'm talking about a crowd, I'm talking about professionals and community members, patients, youth, families, clinicians, administrators, community programmers, and really anyone that interacts with our health system or youth and families. It should be part of our work, and they bring a lot to it. They provide insights to ensure that our programs are culturally appropriate and they're well received by our communities. It optimizes the resources and fosters sustainability. So if we're not building our programs for sustainability to last till next year and then beyond, we're in trouble. And when we engage with our communities, we're doing the best we can on that level. It also builds a sense of ownership of others when they're involved, and their continued interest even when they're not actually doing the work. And that's really important. When we engage policymakers right from the beginning, we get the opportunity to hear what they're thinking about, and we get the opportunity to bend their ear when it comes time to changing the policies that we need to change in order to be successful here. And the other piece I want to remind us is that these folks, these stakeholders that we engage with, whoever we are, always remind us of the things we don't know. They remind us of the risks that we didn't see, and the barriers that we're going to have to overcome. It might seem like it makes it harder, but actually it makes it easier. Next slide, please. This is my first DALL-E graphic, and really what I'm trying to remind everyone here, and I'm sure you've all seen this before, is that we have a lot of places we can engage in our work to improve healthcare transition. We can, and in each of those places, I think we need to engage with others to make sure it happens. We can start talking about policies and social norms, and I'll give examples of these after I run through this. And those have been an important part of changing healthcare transition landscape. And I think, Peggy and Patience have been real leaders in this. We have to recognize that the clinical ecosystem that we're working within, not just our individual clinic, but who our clinics are interacting with, either a big system or a small system, really dictates a lot of what we can do, and it dictates our mindset and how we see things. And then when it comes down to it, I am a clinician, and I think about the clinical encounter and how we can improve the clinical encounters by engaging with people who know more, know different, or are there. And finally, I think it's really important that we recognize that we're talking about individuals, and each of the young people and their families in front of us are different. They bring different life's experiences, whether that's their social and economic experiences, their genetic makeup, their experiences with their health conditions. And we have to really remind ourselves that what we're doing has to be tailorable to those specifics. Even if we're creating a system for everyone, we've got to be reminded to see the individuals. Next slide, please. So that's kind of the landscape of where we can engage. And then I want to emphasize that there's a whole lot of difference in the way we can engage. And we can do it in a really superficial level, and we can go super deep. And to me, this is still a challenge, right? So I think of starting out, well, we got a group together at my clinic, and we sent out a letter that said, hey, just want you all to know that we're now a medical home. We got certified, and glad that we finally made it, and I hope you appreciate it. So come and get your medical home with us. That's kind of engaging, where we told them something, and it's important stuff, but not so deep. We can ask people for their opinions. So we can certainly ask people to tell us what they like more in their clinical services, or we can ask them what they didn't like about something, what we could do better. And that's kind of a little deeper, in that we're actually getting their opinions and a little bit of engagement with them. We can go a little deeper and actually invite them to the table and hear what they have to say, have a dialogue about it. But we're still not giving up any power, and we're not allowing their expertise to really be at the table for their full engagement. I think where it really starts to make a difference, engagement really starts to make a difference, is when we start to collaborate and develop partnerships. And then, there are certain people who are willing to go even further and delegate power and give up complete control of the healthcare system to others. I think it all depends on what you want to do with your engagement and what you're trying to accomplish. So on the next slide, I have a couple of examples. So here I've got those two principles on two different axes. So how deeply we want to engage people on the left, and then what level of the system, or what level we're trying to change across the top. And so my first example is when we want to really think about partnerships and changing policies. There's a great program in Minnesota that I know is now disseminated in other parts of the country, called Partners in Policy. In policy making. And it originated with a group called the Governor's Council on Disabilities, where people were kind of stymied by how are we going to change these policies? How do we, get these things to change? And what they knew was that there were a lot of parents and support people who wanted to be involved but weren't quite sure how to do it. So they developed this curriculum and have been developing it for a long time to teach engagement and involvement in advocacy and policymaking to parents and supporters, so that they can go to the legislature or to the policymakers and engage them in dialogues. So in this case, we were seeking, we're trying to change policy, and we had to dig down deep and not just tell people what to do, but now we've got to be partners with them. The parents and our group are trying to do the same thing. We've got a common goal, and we're now responsible. And thank you, Rhonda. There are many examples of this kind of work. I'm most familiar with the partners in policymaking. Another example would be system change, and this is what I just learned about recently. Includes family voices, where it's often the goal of programs, and in actuality, the Maternal Child Health Bureau, the federal government, to have families engaged in the activities that bring services to their youth. So engagement of families is a critical piece of maternal child health work. Only the federal government isn't quite sure how to get that done, and they were able to partner with Family Voices, actually through a contract, to teach organizations how to engage with families, so that now both organizations meet a goal, and it's taking advantage of the strengths of both. So Family Voices, who has this incredible knowledge, is able to bring it to bear on someone else's goal and their own as well. And then finally, consulting and with others. Let me see if I can remember what I've got here. Excuse me. I think I'm going to skip this guy. Let's move to the next slide. So this was kind of my introduction to deep engagement that I haven't yet done, and I'd love to hear from somebody who's gone to this level. The approach is called EBCD, which stands for experience-based co-design, and this is a approach that's been used in the United Kingdom and in Australia to develop health services for probably 2 decades now, and it really hasn't made its way deeply into the United States. I think our equivalent might be kind of learning collaboratives where we engage families, but this is a much deeper level. This is where EBCD uses a standardized approach to look specifically how people's experiences with the services, including all their interactions with the staff, from getting a notion they want to see a healthcare provider to when they've left and they've gotten their issue addressed. That whole entire experience brings that to the table with the healthcare providers and the system designers. So this is a design process to work out a staged approach to tackling each of the challenges, not just giving the information to the designers or the healthcare providers to fix the system, but really paying and engaging the community members to do that. It appears to get meaningful results, but it's a little tough to know what changes happen there that wouldn't have happened in another way. But I find the evidence pretty convincing that there's a lot more buy-in by the community when they know that their voices are being heard in an organized and standardized fashion. So let's move on then to thinking about what makes successful engagement, I'm sorry. And again, coming out of the Family Voices, there was this initiative over the last few years, I think back to 2015, in fact, where there was kind of finding out what made engagement successful. And these are the 4 topic areas that they believe are critical. And the first is really commitment, I think, on the lower right. And that's that our organization is committed to engaging in a way that is meaningful. And these are not standalone, right? Commitment builds with success. And I think, but we need to start with a little bit of commitment before we dig deeper. We need to make sure that when we bring folks in, they're not just the people that we know. I'm guilty of that often, but you know, to find people who are really representative of the community or able to represent them in some way, in all the ways that we know we're not so good at in healthcare. So really stretching out there a little bit. We need often to seek not just those individuals, but we need to partner with a family organization like Family Voices, because they're the ones that have this expertise to bring in the representation. And that's one of those success pieces. Transparency is critical. When I've run youth advisory groups or youth engagement groups, we've started with a basic manual that includes a preliminary job description of what can and cannot be done by the group. We know that in some of our work, we cannot give youth the power to change a research question. Just not possible in the work that we got funded. But we can tell them that. We can tell them where they can change. And I think they appreciate hearing that up front and knowing what they're getting into. And finally, we have to remind ourselves of the impact that engagement makes. That I don't forget the times when I've been corrected or redirected, and I let people know that. And I appreciate when they let me know as well. So keeping track of that and using that to advance our work here is critical. The next slide, please. And then we move into this notion of how do we know what we're doing and how do we do it. And it's because we keep track of things, right? Whether that's informatics or whether that's by keeping a spreadsheet or keeping our reports. One of the great ways I've seen to do this is the family engagement checklist. Again, from people at Family Voices and others have created a way for us to really get a sense of where we are in our ability to engage with youth or families, and then to monitor that as we're going forward. Hopefully we're getting better at it. But you know, sometimes when we do something like this, we realize we don't know what we're into. So at first we think we're doing it. And then once we dig in a little bit, we realize, you know, we're really not. And so it's not surprising to me sometimes when I'm doing an evaluation to see people say, oh, you know, I'm actually doing not as well as I thought I was at first. That's okay. I think these are checklists that sometimes I refer to as a trigger questionnaire. It gets us thinking about something and moves us on. So this is available at the Family Voices website, and you know, I'd encourage people to take a look and share their thoughts on it. All right, now I want to move on to the part that I have the deepest passion for, and that's about engaging youth, adolescents, and their families. And this is something that I know that not all people are so excited about. Some people, when I see trainees coming through, they're often reluctant to engage with adolescents or parents. They feel intimidated by it. Adolescents certainly have a reputation for intimidating adults. Who knows why? I guess we've all had experiences, but I think when I started to realize what we can do and what it meant to an adolescent when we treat them with respect and we see their strengths, I really turned around and started loving my work with adolescents. So there's sometimes a tension with, can we see take a strengths-based approach with adolescents and ignore problems that they're encountering or they're encountering with their health system? Probably not. We probably need to do both. Take a strengths base, see what they can bring to bear on the problem, as well as recognize that there are barriers they're facing or challenges or risks that we need to step in and help reduce. One time I was facilitating a discussion between a parent and a trainee in pediatrics, and the parent was really emphasizing the importance of seeing what their young person could do. She said, I know all the things they can't do, right? They can't read. They're not going to do this. They're not going to do something else. But I want you to still talk about the strengths, find them, and help leverage them so that we can make progress. And the resident was so befuddled. I remember she was training in medicine and pediatrics, and she said, listen, I'm trained to find problems and fix them. That's what I'm trained to do. And it was just so meaningful to sit there and listen to their conversation evolve as the parents stuck with it and said, I know those problems too, and we can't ignore them. But it's my plea to you to see the strengths in young people, see what they're capable of, and be amazed by it, and don't ignore what we also know as professionals and adults as potential problems. So strength-based approach. Next slide, please. So the second.
4 minutes.
I'm sorry.
Peter.
One more.
4 minutes.
Okay, thanks. Yep, coming up. Perfect. Could you go back one? Creating adolescent-friendly care. Yeah, thank you. So the other point I'd like to make is this notion of adolescent-friendly care, youth-centered care. There are a lot of terms for this. Essentially, this is saying we need to be aware of the space we're creating for young people to come in for care and the approach that we use when they're in there. It's not practical to think that all pediatric practices can be transformed for adolescent afternoon, and suddenly the posters of the little children come down and the posters of adolescents go up. That might be an ideal, but it's unlikely to happen. But we do need to recognize with adolescents that they see themselves as a little different. They may be comforted by the past, but they also want to know that there's a future ahead of them. And so the space should have chairs that adolescents can sit in. They should have posters recognizing the experiences that adolescents are involved in. It should have a web portal that is promising the confidentiality that can be done in each state. It should be accessible with confidential messaging. Finally, the message at the clinic should be that this is a safe, non-stigmatizing place, that no one rolls their eyes when someone comes in and doesn't have their insurance card or is doing something that an adolescent might do. Then the other piece is the approach, right? Respectful, confidential interactions. I think it's critical that we find a way to see all adolescents privately without their parent in the room, and we all need to find our way of making that happen. I have the words that I use. Other people, will find their own words. Adolescents are kind of persnickety. They like to know that you know them as a whole person, not just their arthritis or as their seizure disorder, that they have a physical body that they want attention for. They know they have emotions that are sometimes beyond their understanding, and they're getting control of that, and they live in a social world. Those are all parts of creating health, and they expect us to be engaging in some way about that. And then finally, I think it's not surprising they want us to know the other people in our field, to be able to refer to others who have expertise. So next slide, please. So this takes me to what I love, and that's this approach that's based on kind of motivational interviewing and self-determination theory. So don't get scared by the idea of theory. This is really a practical approach that says when we want young people, anyone, to engage in a health behavior, it really comes down to motivation. That's what gets people to do something. And we know that when people are motivated by autonomous thoughts of that this emanates from myself, I want to do it, I think it's good for me, they're more likely to do it with vigor and sustain that behavior than they are when they're told to do it, ordered to do it, or they do it to make somebody else happy or to avoid punishment. So within the notion of self-determination, our goal is to promote autonomous motivation. And we need tools for that. Furthermore, self-determination says the tool is in helping young people, anyone, develop their fulfillment of their basic psychological needs. And they say all of us, whether you have an intellectual disability, a developmental disability, or are otherwise neurotypical, we all have the need to feel autonomous and competent and connected to other people. In self-determination theory, that's referred to as relatedness. We need a social relatedness or social connectedness. Next slide, please. I'm sorry, did these go out of order? Something happened to my slides in order. Let me get back. I'm sorry. Let's get there. Right. Go down one more, please. This one was out of order. So in self-determination theory, we know that we want to move people to these sustained health promoting behaviors. We know that we want to do it through motivating autonomous behavior by seeing that people have their needs for autonomy, competence, and relatedness met. And here's where we do it. We do it by supporting their needs for autonomy, competence, and relatedness. There's strong evidence in the adult literature that strategies that help people make decisions or feel they're making the decisions from their own point of view are effective in changing health behaviors. I think we can believe and work on the ideas that people need to feel competent and connected. I hear plenty of stories from young people about the importance of social connections in determining what behaviors they'll be involved in and what they're not. So it becomes our clinical goal to engage them. Tell me, what are the choices you see you have in this discussion about what medicines you take? Would be a simple way to go about that. Can you next slide, please? I'm running a little behind on time. Here are some of the phrases that I use and some of the strategies that I use when I'm promoting these basic needs and the skills that go along with fulfilling those basic needs. So when you are a good problem solver, you become competent. When you're making decisions, you're becoming autonomous, or you're feeling autonomy. And when you are a self-advocate, you're really building the skills for relatedness. Next slide, please. And this is where I want to wrap up and go back to where we started and then just move on to the discussion. Really, I find it so important that we remind ourselves that what we're doing together when we engage is to improve the health and well-being of the youth that we're focused on. We do that by working with others in other fields, with families and with youth themselves. It creates a better experience for all of us. I think thinking about the aim of the quadruple aim in the healthcare language, that we need to make sure that we are being fulfilled in our needs. And when we do this engagement, I think we're moving along that path. Can I guarantee that engagement will increase our efficiency in what we do? I can't, but I think that when we take a long-term view, we believe that we avoid the mistakes when we engage with others, and we can decrease the costs when we avoid those mistakes. So we can meet those goals of health, equity, and efficiency and costs, and preserving our own well-being as well. So my brief tour of engagement, thank you very much. And I'm really looking forward to our discussion in the case.
Wonderful. Thank you, Peter, so much. Of course, I think we all can understand that engaging with youth is so important. I wonder if there's maybe one question that we can take before we move on to the second part, if there's anything. Otherwise, we can always drop it in the chat and have Peter answer them in the chat as well. Righty. Well, I think we could not have had a more perfect case for further discussion of this topic. So I want to introduce first Debbie Harris will be leading the conversation after this case. And the case will be presented by Dr. Kelly Cho. Dr. Kelly Cho is a pediatric physical medicine and rehab provider at Gillette Children's. She works in the pediatric spina bifida clinic, and I'm very lucky to get to collaborate with her on how we create safe and effective transitions to adulthood from our pediatric to adult spina bifida clinic. So I will let Dr. Cho explain her case.
Yeah, hi, thanks, Tori. Nice to see everybody, and thanks for having me. Some of the inspiration for this case, as we try to really take a deep dive at Gillette in our policies and processes and supportive networks, to really embed the idea and support around transition to adult healthcare into the work that we do, and with the goal to make that accessible for all of our patients at Gillette. And the inspiration for this case in particular came up as we are working through some benchmarking through the CDC for our adult spina bifida clinic, kind of drawing on some things that we were doing well, but then also identifying some things that we could be doing to improve that process. So, greatly timed. This is based on a case that I saw last week in our spina bifida clinic. So we can go to the next slide. So this is a 15-and-a-half-year-old young lady with mid-lumbar myelomeningocele and shunted hydrocephalus. We actually hadn't seen her in clinic in over 2 years, so there was a lot of catching up. She has an asymmetrophenol for neurogenic bowel and bladder and reports continence with management of those, which she's cathing independently 5 times a day, and then with some family assistance using Parastine, which takes her about 35 minutes daily. She noted irregular menstrual cycles and kind of some frustrations around that. But the biggest thing in her medical history was that she underwent a anterior spinal fusion in February of 2022 and has really struggled with that post-operative course. Some of the things that were happening even outside of the spina bifida clinic over the last year, I would say, is addressing what she and family felt like was new right-sided weakness, particularly in her right leg after surgery, as well as dysesthesias and a sensation of pins and needles, a lot of pain, a lot of muscle spasms. She had been kind of working with neurosurgery to approach that, and she is shunted, and they kind of work through that process. Neurology also saw her kind of given these new concerns, and overall has, she and family has felt like her symptoms are improving. So that was reassuring, and really kind of nothing else super off of her baseline with regards to her exam at that point. So no further workup was pursued outside of already past imaging that she's had to make sure that, there wasn't anything new in the spine. And neurology also was treating her pain and spasms, which were what she cites as some of the most limiting for her day-to-day. She does have underlying history of anxiety and depression, on medication, and gets psychology support for that. She's in 10th grade. She has an IEP. She really enjoys theater. Isn't really sure what comes after high school and some of the questions that we were kind of asking. So some of my work, for individuals at this age are really to draw them into the conversation more and to really understand their function and what's important to them when it comes to their care and their bodies and their quality of life. So we can go to the next slide. So she's independent at a wheelchair level, FMS of 1. She has always independently transferred, but noticed that it was more difficult, especially if she was on the floor. She also would crawl at baseline, and that has been very difficult since her fusion. She's independent with her ADLs, but some struggles with lower body dressing. From an equipment standpoint, she had outgrown her manual wheelchair. She overall, I would say, had some subtle weakness on the right side, but pretty, stable and baseline strength. She did have no sensation at the feet. And then one of the other things that she's really struggled with since I would say probably 9 or 10 years of age has been her weight. And she acknowledges that things have not been moving in the right direction. You can see her Z-score here. So she's really also trying to work through that, which, potentially could be contributing to her challenges with her function. So in kind of reading the room, she did do some outpatient PT over the summer that didn't go very well. I felt like with what they were sharing and her mom's kind of thoughts on things, that a gentle approach to mobilization would be needed. So she's really interested in the pool and felt like that would be a good way for her to start working on moving again and, kind of eliminating gravity when it comes to, what she understands is like also, having to move her body in light of, her weight gain. So we did provide a referral for that. We talked about trying to get her engaged in, other activities. She had done some adaptive sports as a younger child and, kind of speaking to some of those adolescent changes and the ways that they kind of change their interest in things. So therapeutic rec was also something we had talked about, looking into a new manual wheelchair for her with, potentially smart drive power assist to help take some of the stress off her upper body. We talked gently about her weight struggles, and both her and her mother were interested in just getting some very objective, unbiased information from our dietitian to help with that, and then also updating her neuropsych testing. But one of the things that I also had the chance to do was to introduce the concept of, at our next visit, giving her and I some time to just be in the room together without family present. And I wanted to kind of present some of my thoughts with how I would go about doing that, and then also pull from the expertise on this call to help me. So we can go to the next slide. So these are some of the questions that, have come up in some of our conversations within Gillette, and just things that I've been thinking about with regards to how to approach this. I feel like, her age at 15 and a half was a good age since, we just were reconnecting to start to implement this, but wanting to kind of hear from people, are you starting this earlier, starting this at 13? Really what has been kind of people's experience with, how soon to start this. And then, I tried to do my best to introduce this concept, but any advice that people may have on, how to gently introduce this, also to make it clear that, to parents that we're not, this is for the benefit of their child and not something that, you know, we want to hear from that individual without them, or, you know, try to, you know, get things for them to say behind their backs or something, you know, just really kind of leading with this isn't that. And this is just something that we're trying to do to practice, you know, these individuals being autonomous in their care and really asking the questions that they feel are important to them. Some of the other questions with regards to logistics that may be easier to address is, you know, when do we do this? So like my initial thought was, you know, kind of do the visit and then spend maybe the last 5 minutes at the end of the visit to do this. During this time, you know, where are you having families go? And I know in this case, the mom was, you know, pretty laid back and she's like, I'll, you know, just go to the bathroom or something, take some time for myself. But are we like providing them chairs outside the door? Are we, you know, escorting them to the lobby? And, you know, who's bringing them back and things like that. So like logistics. And then also in thinking about, and this is maybe some of the, you know, really help that I want from this group is, you know, what are some examples of things that you guys have found successful to give them as far as like, you know, ideas of things that could be discussed? And then how do you guide conversations if that individual is being an adolescent and has no questions? And then, you know, we talked about the notes. My partners have kind of wanted to know, you know, we're going to talk about this. I want to remember that we talked about this. So, you know, we thought about putting that in more of a protected note. But, you know, is there a separate billing since that's an additional note, or we just kind of include that in the whole time of the visit? And then I guess, like, how do you bring families back and say that something comes up that you're needing to put in a referral for? Like, how, you know, how does that work? And I think, you know, again, in you know, speaking to the approach of this isn't anything to hide necessarily, you know, from family, but, you know, if there are sensitive things that would require further referrals, like, how do you address that? So, so these are, I know I presented a lot of thoughts and scenarios. We can start, I guess, with one of them, but those are just kind of my thoughts around this case as I'm working towards that for next time.
Thank you so much, Dr. Cho. I think we'll start by asking our participants if they have any clarifying questions about the details of the case first. And Katie, could we maybe can I see the participants so I can maybe see if any hands are raised first?
Can you see it now, Debbie?
I can, yes. Thank you so much.
Just checking.
Thank you. And if I'm missing someone, just maybe take yourself off of mute and just let me know, because it's a little bit difficult to see all of the screens at one time.
Debbie, I put a question in the chat. Kim Smith, I'm not sure if you're still here, but when Kim introduced herself, she works at a primary care clinic, pediatric primary care. And I'm just wondering, Kim, how your clinic does time alone.
Sorry, I had to find the unmute. You know, I mean, when I didn't actually participate in all the actual visits, so my providers, I think they just asked the parent to step out, but I can't really speak to what they actually do. But I can ask next time I do a visit. But I don't, for myself, when I meet with the family, I can speak to a child alone. I would just ask the parent for that time frame, but it's not something I know. Oftentimes I'm dealing with the smaller children, early childhood, autistic, trying to get things moving for that. So the bigger kids, it's not as common for me to be involved, but when I am, it's that transition piece is hugely a problem. Finding the resources, getting them changed. So Yeah, I will ask though. That's a good question. I apologize. I don't know.
Thank you. Thank you, Kim. Any other questions? I was wondering, if you do come across anything with the patient that is maybe considered confidential that you might not want to share with the family, how do you approach that? And I know you had alluded to that a little bit in the discussion of the case study, but how would you handle that once the parent comes back into the session? Any suggestions?
Yeah, I guess that's kind of what I'm looking for. I don't know if it's something that is confidential. My first thought is, we don't have to like disclose that. We can kind of continue to wrap up, goals of the visit that were discussed with the, family or caregivers, and kind of, again, it's like the end of the visit. So then you're just focusing on like, discharging and things like that. But
Mhm.
Hi, my name's Betsy Hayes. I'm a general pediatrician in Kaiser Permanente in Oakland.
Mhm.
And I think what you could do in your clinic is just normalize it that every patient over the age of 12 does have a confidential portion of their visit with you. And if you normalize that, and you can let the parents know why, confidentiality laws are different in different states. In our state, it starts at 12. But if you just normalize it for every patient, then you have the opportunity to talk to the patient alone and then code anything you want that's confidential in a confidential part of your chart.
Thank you. And I see in the chat, Dr. Scal says some clinics have a sign that says that visits with teens 12 and older will include some time privately with the doctor as well. And I wonder too, when we embark upon a transition with families, if there's some gentle way to include that as part of the transition discussion with families to kind of ease them into the whole process, that there might be part of the transition process that includes private time with the adolescent.
Well, there's some thoughts that if you do a policy or a guide around transition, this should be a major component. In other words, you can say at age 18, things happen. At age 12 in our clinic, these things happen to, and give them a good reason why. So everybody gets it very early, even before. And then you obviously are giving this kind of guide or policy out. Some people use it as an after visit summary. It's sort of part of the 6 core elements. So it sort of loops in what Peter's talking about and what you're talking about, that it's just plain, this is how we do it at this clinic, and it's no surprise. I think what gets families most is the surprise about age.
Thank you, Patience. I think we lost your last few words there at the end. Or is it my computer?
I didn't catch it either.
yeah, I couldn't hear the last
Okay.
couple. Yeah.
I think Katrina had her hand up for a short bit.
Okay.
Hi, I did. And I was on earlier, before I got back to my office. I was on my phone earlier listening when I came in late. So I am a nurse consultant with the Florida Department of Health, and with our children's medical services system. So Dr. Patience White has spoken to the collaborative group who helps bring our clinicians together with NICHQ, Dr. White. And so I engage with many of the clinicians throughout Florida who serve the children that have specific conditions, right? So they're divided up into categories, and currently we have a statewide project, quality improvement project, that's centered around aspects of pediatric to adult transition, right? So I received this email and I wanted to come on and kind of get an idea of what that project should look like so that I could share that information with those clinicians. It came to me and I didn't think that I was appropriate for it because I'm not in the clinical setting, but I do engage with people who are. So I wanted to make this available to them to see if they wanted to participate because they are already actively engaged in quality improvement around transition. So do they have, is there some, once I release the email that I received, would they have someone they could talk to that might be able to give them information about what the expectations are for this?
Yes.
Okay.
We're happy to connect. I'll have Katie send you her information so that we can answer any questions.
Thank you so much, because I'd like for them to have someone to speak to directly to get an idea of what the commitment would be like, and it would be great if they could participate in that.
Perfect.
Thank you.
Mm-hmm.
The other thing I'd say, Kelly, is it's helpful to talk about those things before you let the parent leave about what is truly confidential and what is not confidential. For example, if they're talking about hurting themselves, suicide, like those are things that you're going to gently talk about with whoever their guardian is that came along with the visit. And then like everything else is fair game, really sets the stage that, you know, this could be anything that I want to talk to them about. And then I typically do it towards the end of my visit as well, but also struggle with like, where does mom and dad sit? I'm going everywhere. Like there's a lot of time that it takes for someone to walk down the hall and get them, etc., in a short period of clinic time. So when we were remodeling our clinic, that was one of my questions for you know, like where are we going to be able to have this space for parents to be during those periods of time where they might not be there.
Thank you.
Yeah, that's helpful.
Yeah. And I like the suggestion in the chat to use icebreakers to get the adolescent to talk about how their condition impacts their life, because it makes the whole approach holistic and more organic, so that you look at the adolescent as a person and not just the condition. So I do really like that suggestion, just having had, you know, having had three adolescents, boys. So thank you. Any other questions or suggestions? We have about 3 minutes, I think, if I'm on time.
Just one quick comment. This is Becky with social work. I think, and Peter mentioned it earlier too in his presentation about having somewhere in our transition information very clearly spelled out confidentiality and state by state what limits there are and what is, and so I think that should be a part of something. My background in clinical mental health before I came into medical social work kind of informed me about this too. But when I meet with adolescents now, and when I did then without parents, I made it real clear at the beginning of the discussion with the young people as well to say, hey, you know what, this is our time. Here's confidentiality, you know, this is what it means. But I also talked about exceptions, and I laid it out, and I said, so for example, if you say something to me like, and I would give a couple of examples of things that I would not be able to keep confidential. And so they knew that right at the beginning. And I said, it's not that I wouldn't want to help you with those things if those were true for you. I said, in fact, I would very much want to help you with that. And, you know, so we can talk if you have questions about what that might look like. Or if you have a friend that you think is going through some of this, and sometimes we'd have kids say, well, I have a friend who, we've all known that, right? And they're testing it out and they're saying, so what would what would happen? That's important. I know it can take time, but I think if they understand that up front, boy, you'll lose trust immediately if they say something about, you know, self-harm, and it's, you know, and then all of a sudden we say, well, confidentiality off, I got to tell your mom. Well, I should have known that up front before I, you know, so that would just be one thing. that I would say we need to make really clear, about what that is.
Thank you so much, Becky. It's a wonderful idea to maintain trust. I think we're going to wrap it up now. Thank you so much for that compelling case study. And please look at some of the other suggestions in the chat. And I'm going to hand things over back over to Tori. Thank you.
Excellent. Well, I'm just so impressed by the wealth of knowledge and experience in geographic areas across our learning collaborative. It's so exciting to see. So our next session will be after the holidays. We'll be talking about supported decision-making and guardianship options for collaborative decision-making in January. In addition, there are 2 opportunities to get involved further with this program. One is this healthcare transition learning opportunity where you can take a transition-related process that you're trying to implement into your clinic and get the amazing opportunity to get to sit down with Peggy McManus, Patience White, and our team here at Gillette to really talk through how do you make that happen. So your ability to say, I have this QI project, I'm not sure where to start. How can I get some advice from experts who have done this and then implement it in a systematic way? The goal of this is that it's a teeny tiny small project, right? It's only 6 months that you have in order to get it off the ground and rolling. So it's something like, how are we going to universally have patients who are 12 and up have a little tiny bit of time outside of the room? What are the things that we need to do in order to make that happen? Is it chairs outside the room? Is it a document that we share on the clinic wall? These are the sorts of things that are possible in a 6-month time span. And then you'll get to present a poster at our Healthcare Transition Learning Collaborative. We're happy to answer any questions. The deadline for applications is December 13th. So coming up quick, but it's a very, very short application. Shouldn't take a long time. So we, of course, really, really are excited to offer that opportunity for folks. Next, our second opportunity is that we would love for you to present a case. So just like Dr. Cho came on today and said, I have the situation, how might I be able to address it? How can I get real-time feedback on it? That can be you. That's the QR code on the right. And then we want to keep making this more and more useful to all of our attendees. So we encourage you to fill out the evaluation. There's been a link in the chat. There is the QR code there on the left. And with no further ado, thank you so much for spending your lunchtime with us. We are so thrilled to be able to come together and learn about transition together. We'll see you next month.